Assalamu alaikum. Welcome to Ruxana Foundation's YouTube channel. Today we'll be discussing some high yield concepts from arterial supply of GI tract. We'll begin with celiac trunk. As far as the arterial supply of GI tract is concerned, there are three major arteries that supply the whole GI tract. The first one being the celiac trunk, the second superior mesenteric artery, and the third inferior mesenteric artery. The celiac trunk, it is further divided into three main arteries. The first one being common hepatic artery that supplies the liver, splenic artery that supplies the spleen, and left gastric artery that goes up along the lesser curvature of stomach. Now the questions won't appear like this, that they will be demanding an answer about the particular supply of a particular gland. What they will be looking at is the clinical significance of the arterial supply. If you could look at this image, you can see this is the celiac trunk, and here is the common hepatic artery that is further being divided into the gastroduodenal artery. Please pay attention to the fact that gastroduodenal artery is making its way along the posterior surface of the first part of duodenum. In terms of ulcers that involve the first part of duodenum, this is the gastroduodenal artery that will get eroded away when the ulcer will perforate the duodenal area or the duodenal wall. And when that happens, bleeding will begin. That will result in peritonitis, and particularly if it is prolonged, might lead to sepsis and even patient's death. If we talk about this is the gastroduodenal artery, it lines the posterior wall of the first part of duodenum. If we talk about an ulcer that is present on the interior wall of the duodenum, it will lead to an air under diaphragm appearance on an abdominal erect X-ray. So this is very high yield that if an ulcer is present on the anterior wall, it will lead to air in the diaphragm, and if it's present on the posterior wall of the first part of duodenum, it will lead to bleeding. The next topic is portosystemic anastomosis. As far as the venous drainage of the GI tract is concerned, it is composed of two major vascular systems, the first one being portal and the second one being systemic system. The portal system, it involves drainage of venous blood supply from the body, from the GI tract into the portal vein that will then take it through liver to inferior vena cava. The systemic circulation or the systemic venous drainage of GI tract will follow its route through inferior vena cava. There are three key areas in this GI circulatory systems that the portal and systemic systems collaborate with each other, and they form sort of collaterals. And it is because of these collaterals, if blood pressure in one system increases, the other system will automatically compensate for that. The first part or the first area where this portosystemic anastomosis is present is the esophagus. It is very important to know that which system or which vessels belong to the portal system and which vessels belong to the systemic system, because they're gonna test you on USMLE Step 1 with this. If we talk about the esophagus area, the portal system here is formed by the left gastric vein right here on the lesser curvature of the stomach, and its counterpart is formed by the esophageal veins here that are part of the inferior vena cava drainage system. This is very high yield in terms of cirrhosis of the liver and hepatocellular carcinomas, because in that scenario, the liver won't be able to absorb the blood coming to the portal system, and from portal system into the hepatic vein and then into inferior vena cava. And when that happens, the blood supply will automatically get shunted towards the left gastric vein and then towards the esophageal veins. As far as the portal system and systemic circulatory, the systemic venous drainage system of GI tract is concerned, the valves are either not present or they are very poorly formed. And because of this, these veins automatically get dilated and may lead to hemorrhagic shock. In terms of porosystemic anastomosis and their clinical significance, the most likely mechanism that will appear on your USMLE Step 1 and even Step 2 exam is going to be about cirrhosis or hepatocellular carcinoma. The second area where this important anastomosis is present is around the umbilicus. Here, the portal system making its contribution through perumbilical veins. The systemic system makes its contribution through small epigastric veins. And the thing that we will examine on patient's abdomen would be capute medusae. As you can clearly see this image from Google, how capute medusae is showing dilated these portal and systemic vasculature. The next area that is important in terms of porosystemic shunting is the rectal area. Here you can see how the superior rectal vein is a part of the portal system. It is being drained into the inferior mesenteric vein that then gets drained into the portal system through portal vein. The systemic counterpart of this anastomosis is found by the middle and inferior rectal veins. That you can easily see here. You can easily appreciate from here how these are being drained into the inferior vena cava system. The rectal varices that happen, they're very high yield in terms of scenarios that include internal hemorrhoids or external hemorrhoids. So they're gonna appear in your surgical part of a USMLE exam. One key concept that needs to be highlighted from here is about a porosystemic shunt that is being made by doctors or surgeons in times when there is cirrhosis or hepatocellular carcinoma and there is no other option available. Currently, let's say the patient might be on waiting list for a liver transplant, and just to buy time, surgeons might make a shunt between the portal and systemic circulation from portal vein towards inferior vena cava. Now, this might relieve the pressure in the porosystemic circulation, but this is going to exaggerate the hepatic encephalopathy. That happens because the liver is involved in the detoxification of ammonia, and when that ammonia does not get detoxified, it's going to get absorbed into the systemic circulation, and from there it's going to make its way to the brain. So that's why it's very important to highlight how tips might be life-saving but at the same time might be devastating. The next high yield concept about GI system is hemorrhoids. To understand the anatomy and pathology of hemorrhoids, we need to know what a pectinate line is. Pectinate line is an anatomic landmark that traverses two parts of lower GI tract or the very lower part of the GI tract. You can appreciate here how pectinate line is dividing the anal canal into two parts. Now, these two parts that are being divided by the pectinate line, they have different venous drainage, they have different arterial supply, their histology is different in terms of epithelium, their lymphatics are different, their nervous supply is also different. If we talk about the definition of hemorrhoids is dilatation of anal venous plexus. The area above the pectinate line, embryologically, it is found by the endoderm, and the area below pectinate line is found by the ectoderm. We clearly know that endoderm receives visceral supply, and with visceral supply, I mean that if a patient gets internal hemorrhoids or hemorrhoids that involve the upper portion of the pectinate line or the portion above the pectinate line, then that pathology will not result in any painful. That's why internal hemorrhoids are very notorious for not being painful, and continuous bleed might be a challenging scenario for a patient and also for a doctor to know if that hemorrhoid, if that bleeding actually is coming from hemorrhoids or some other part of the GI tract. For hemorrhoids, whether they are internal hemorrhoids or external hemorrhoids, the bleeding is going to be fresh bleed, bright red in color. If we talk about bleeding from the other parts of GI tract, let's say from an ulcer coming from upper GI tract, that will appear brownish in color. But for hemorrhoids, the blood is going to appear bright red. Coming back to our scenario, that external hemorrhoids are formed when venous plexus below the pectinate line is involved. That might happen because of any etiology. Let's say it might happen because of constipation, old age, or even cirrhosis. Then the external hemorrhoids are going to become very painful because they receive somatic innervation as they are formed from ectoderm. USMLE also is gonna test your knowledge about the arterial, venous, and lymphatic drainage of both these areas below and above the pectinate line. So it's very high yield to know how arterial and the lymphatic supply is different for both of these areas. Next high yield concept is about an anal fissure. Anal fissure is simply a tear in the anal mucosa, mostly in the posterior part of the anal canal below the pectinate line, and it's very painful. And when that happens, you cannot even do proctoscopy or do digital rectal examination of the patient because it exaggerates the pain the patient is already experiencing. And it's most of the times it's associated with hemorrhoids, constipation, or even in terms of sexual trauma, this might be a sign to look for other um, things that might be related to a physical trauma. In terms of treatment of all these three high yield concepts, internal hemorrhoids, external hemorrhoids, or anal fissure, we're going to ask the patient to increase his or her fiber diet. We're going to ask the patient to increase the fiber in the diet along with increased water intake and to avoid red meat. Okay, that's it for today's lecture. Thank you so much for watching our channel. Please do like, subscribe, and press that bell icon. Thank you so much.